How many surgeons are in the room? Okay. How many orthopedic surgeons? How many neurosurgeons? How many people use image guidance? How many use it a lot? Izzy, you do? Robotics. You do robotic stuff. Do you use image guidance like I'm talking about today, non-major?
No, not line of sight track.
Thank you. Okay. Okay, how many people use it? How many people are not users but use it once in a while? Okay, a few guys. And we'll ask those questions as to why you may not use it. I'll go on some of the other questions. Yeah, who used it and does not use it currently? One. Okay. Who would like to use image guidance? Who would like it to work better? Oh, that's even a question. Okay. John Kostwick raises 2 hands. So, okay. I love the pictures that go with these things. So this is a poll. I just love to take poll because, it's how did I get interested in this? Being a country guy from Montana, raised on a ranch, riding a horse. So, who has access to image guidance? Everybody? Anybody not have access to image guidance that's a surgeon? Charlie, you don't? No? Okay. All right. What should we use image guidance for? I mean, what would you do it for? Those are questions we'll try and talk about as we go along. What do you know about image guidance accuracy? Do you know much about it? I mean, these are questions just for you to think about. Who feels IGS could work if some bugs were worked out better? Only a couple people? Okay. Well, that's an important one, too, because there's a few things that I'm going to address that have always been questions. Everybody does spinal instrumentation surgery, I presume, right? Is there anybody not who's a surgeon who doesn't do complex surgery? Okay, you're at the master's course, that's why. Okay, who does complex spinal deformity surgery? Okay, who doesn't? Okay, a few guys. All right, I do a lot of complex stuff. I think that, watching these lectures today, it's like Jens, is that, I have a mirror image practice in Los Angeles, and I learned a lot of stuff from him, by the way. He's a brilliant, brilliant guy and a great surgeon. And I can just sit back and listen and look at some of those things and go, wow, I got to learn how to do that stuff, or I got to go home and do it now. Who does revision surgery for screw placement problems? Yeah, so you get patients come, they've had a previous surgery, whether it was 2 years or 10 years ago, they've got a deformity problem that may be a result of a degenerative problem that was fixed. Okay, so those are great cases you're adding on, or you got somebody that had a floating fusion from L2 to L5 and they kyphosed above and they worn out L5S1 below. What do you do with those things? Izzy, that's probably your practice. That's bread and butter probably of your practice. It is mine as well. And when do you use image guidance for those kind of cases? So a little bit of history. I'm not going to talk too much about this, but it all goes back to Röntgen. I mean, he designed and came up with the concept of designing radiologic imaging of the spine. And here's kind of an interesting picture. World War I. Okay, some guy had this radiation device and he had put on this thing that was like a image intensifier that was on his head, and he took bullets out of people with this thing. Houget in France, okay. Professor Dubussy, have you heard of this fellow?
I know, yes.
Yes?
It's very, very well known by French surgeons because it's developed during the war when the Americans came to save our country.
Wow.
Yes.
Wow, so I credit that as the first image-guided surgery, maybe. I would go.
Yeah. Even on close to the battle, very close to the battle. Marie Curie.
Yes.
Had cars equipped with some Röntgen. To remove the impact and the
shrapnel and bullets.
The shrapnel, yes. So it was guided from that time during the war.
Kind of like what I did at the Army Hospital in Germany during the Iraq War. A little different technology then. So Godfrey Hounsfield, it all goes back to him creating a CT scanner because a lot of this stuff is CT based. There's other guidance system. Izzy talked to us about the Maser a little bit. There's other things, fluoro technology, but the CT scanner, which a lot of image guidance is. So what is navigation? I mean, it's basically kind of a celestial navigation technology that you have points in space. In fact, celestial navigation works on the stars that are out there. Okay, and this goes back, and actually some of the original frameless technology goes back to Ian Kalfas, probably published one of the first papers in '95. And really the goal is just to improve what we're doing. And this talks a little bit about celestial navigation. I mean, those are points in space. I mean, the North Star is one of those points among many that the ancient mariners, and actually we still do today, is that you know where you are in space because the North Star, it's so far away, it never changes in relation to the Earth. I mean, so it's there. And that's what happens with image guidance, is that you create an environment where you have points in space that are defined, and you got a high-speed computer system that's looking at these things, and it's kind of like stars or the reference frame, and also the instruments that you use in your hand. I mean, it's just like celestial navigation is what it is. And, these are some of the pictures that, it looks like intraoperatively. And I say it's like video games. And I look at some of these things, and it's just amazing how far it's gone. This is first generation. I started putting thoracic pedicle screws in, and I can date it. In fact, I look back, it was 1997 when my fellow Ki Kim, who's up at UC Davis now, did this first study. And he was putting in the first thoracic image-guided pedicle screws in cadavers, and he did this study, which was just the feasibility in teaching himself and us how to put thoracic pedicle screws in with image guidance in cadavers, and published it in Spine, which I thought was really forward thinking, but I never thought we'd be where we are today. It's amazing. So this is actually the paper, put in thoracic pedicle screws and looked and said, how did the surgeon learn, how did we learn how to do this? We were never putting them in clinically. So we're really what I consider a second generation now, rather than us having this impossible way. I mean, who did image guidance before you had a CT scanner in the operating room? That's another question. Who did image guidance like, 6, 8, 10 years ago? Yeah, when you actually had to bring a CT scan in and put it into the computer, and you had these points and you had to match them up. How impossible was that? How many times did you use image guidance then? Once or twice a year? It actually worked well in a couple places, and just is a little divergence but off the topic, but where it really worked was places like the sacrum. We were just talking about that. Jens Chapman was talking about the sacrum is where if you had a tumor in the sacrum and you couldn't find it, it was somewhere inside of the sacrum. That's a perfect place. I would go back and I'd do that point registration, and I would use it in a lot of different places, and we published a whole bunch of papers about weird places that we would use the image guidance system with that point matching stuff. That's all gone. You got an intraoperative CT scanner now, and you got all this technology. You go in and you do the CT scan, and it feeds it in at the speed of light you've actually registered. And so it's pointing, okay? It's point and shoot. Okay, so it's changed the whole thing. Okay, and these are all these different systems this is a few years old, and some of these things don't even exist now. And now it's down to about 5 companies, I think. If I'm missing somebody, I'm not here advertising anybody or anything. I have no disclosures. BrainLab has a system that I'm least familiar with this one than any. Medtronic has this O-arm, which is married to the Stealth system. Neurologic is basically a CT scanning technology that's marrying up with some of the other software and imaging station navigation technologies, but it requires a pretty big operating room, specialized tables, things like that. Siemens is a little bit the same way. They have this fluoroscope, which is all a CT scanner is anyway. And these things create CT-like scans. Stryker has a whole system that they're actually branching into ENT, cranial, orthotrauma. They're doing everything. So and spine is one of their big ones. So, what are some of the perspectives about navigation, spinal navigation, and doing these things? Is that it should only confirm what you're doing. I mean, this is where you need to know how to do these operations without a fluoro if you don't have it. I mean, if you ever work in a third world country, I went to Cambodia, and they said, well, where's your fluoro machine? They said, well, it's out in the next room. Well, of course they don't have image guidance. I said, well, do you want to bring it in here? They said, well, it hasn't worked for a few years. I go, okay. I guess we're going to do without. So it just confirms the anatomy that you know. You got to be a good surgeon. I mean, it's like the pilot. When you're riding in an airplane, traveling somewhere, and all the navigation system goes out, the computer lands those airplanes, the airliners nowadays mostly. But if it quits, you want the pilot to know how to run it, right? So is your patient. Your patient wants you to know how to run these things. So if you see any kind of discrepancy from your anatomic knowledge, you got to have some kind of algorithm. You check your instruments, you check everything. You can go back and recalibrate all of your instruments, and then you figure out what the thing is. Have a low threshold to recheck everything. And these are just some of my quotes that I use every day on the fellows. It's like spinal instrumentation is pretty easy. It's only about entry point and trajectory. And if you think about that, when you're putting hardware in, these last lectures that you heard, I sit back there and I just scratch my head and I say, these guys got to be incredible surgeons, because I couldn't put in all of those iliac screws. I've done it. I've put iliac screws in, but doing a transsacral to iliac screw, I mean, how does Jens know that he's doing that? I mean, he's got to be the most incredible surgeon on the planet to be able to put those things in reliably. So what I do is I just go in there, I spin a CT, put a reference frame on, spin a CT scan, and I do it like video games. I just go boom, 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 and I can recreate what he's got on a post-op CT scan. I can recreate it, on a preoperative image, and that's kind of my goal. And that's why I say to the fellows and residents, surgery is simple. It requires only a knowledge of anatomy and hemostasis. I mean, how to do that. Surgery is simple after that. And then I say it's really simple, just do it perfect, because they got a computer guidance system, and these guys are in the video age and era, right? You know how to run a video machine, right? This guy's nodding his head going, yeah, I get it. This old guy up here, he doesn't know what he's talking about. He doesn't know how to run those computer games. So you can do all kinds of things, and these are some of the trajectory things that you can do. These are the pearls of what you can do. How do you put in a cortical screw? You heard me ask those questions. I say, how do you do this? Okay? Have I ever put in a cortical screw? I'll bet I have and didn't know it, because I just use these kind of trajectories in various ways and stay away from the facet joint. If you look at this and you look at some of the trajectories of just this screw, okay, some of it's going to go right through the facet joint. It's going to destroy the facet joint. If it's an adjacent level, that's a bad problem. You don't want to do that. So the image guidance system allows you to do these things. We even do closed percutaneous procedures nowadays that we change our trajectories so we stay so far away from the facet joints that the tulip head on the screw is never going to be anywhere near the facet joints at the adjacent segment. Because preservation of those things is absolutely key to the long-term success. Okay, aside from the short-term success of getting those patients to heal. So that's where, these are custom trajectories. And if I'm understanding it right, the lower right picture is one of the more cortical-like of entry, I guess, but you have to look at it in different planes. And so this is one of these things, I could talk for about an hour just with this one picture here. You don't want to listen to me that long. So what are some of the negative perceptions about it? Okay, well, cost to benefit, I'm not so sure about that, because what if you have one lawsuit? Okay, you put it through some place, you say, okay, you can figure that one out. That's not a good one. But there's a lot cheaper things to think about. Lack of clinical evidence. Well, there's so many papers, and I'm not going to go through many of them. I'll cite a few of them. The whole radiation issue. Okay, what's the radiation issue? Okay, the surgical team doesn't get any radiation. I don't even wear a radiation badge anymore. I quit using fluoro. I just use image guidance. In fact, I don't even know when the last time was I wore one. Now, the radiation to the patient, sure, the patients do get a CT scan done on them. So what are some of the other questions? If somebody needs navigation, should they be doing spine fusions? I guess so. It's difficult to use, lengthens operating times, too many intraoperative glitches. Everybody agree with that? Who's used image guidance and agrees with that? I see smiles over here, right? Okay, well, there's more smiles. In fact, the more I look around the room. The accuracy, I mean, we'll talk about that more in a minute, and the radiation, we talk about these things. What are the costs of these things? I mean, just put $1 million price tag on any one of them. That's about right for an image guidance system, including the imaging and the navigation technology. You got two different components, then you got software. So just figure it's probably about $1 million. And there are some studies that look at the cost effectiveness of spinal navigation. And they look at cost savings per 100 cases, that if you have to go back and redo anything, it's IGS revision rates versus freehand, and they're not necessarily standard or comprehensive. So this is just looking at more of the different studies that, the conclusion is that it increases the accuracy, reduces surgical time. I'm not sure everybody in this room would agree with that. And the radiation in the thoracic deformity correction to the surgical crew. But this is kind of a summary, okay, is that the freehand technology that we've all used is probably in an accuracy rate in the 80s, fluoroscopy in the 90s, really experienced surgeon. You bump these things up, I mean, but if you're not doing these things every day and you're just not, you know, someone who has that experience to do that, maybe the image guidance is the way to do it, because the accuracy rates are approaching, you know, high 90s. Okay, are they going to be 100%? No, they're not. So the revision rates, if you just look at all these papers, and this is kind of my own little meta-analysis of a lot of papers that are published out there. You know, what are some of the issues that we have? Okay, it's currently now, and there's some changing technologies, the reference frame, and there's just different strategies of how to do it. There's some different reference technology that's coming along that's going to eliminate the reference frame, or it's going to change it to different referencing with some of the current technologies that are coming available. But we will use things like clamp to the spinous process. Where you put these things is important. For cervical spine, we will use the Mayfield frame attachment rather than using a spinous process, and I'll show you some pictures of that. And you can even in the thoracic and lumbar spine, if you have a patient who's had a revision or is having a revision, go in, open it up, take all the screws out, replace them, and then you're going to add on to it. You can use a device that we actually made one homemade that you can clamp to the existing pedicle screws with a J rod is what we call it. Percutaneous, we even use things like a pelvic pin, or sometimes we will open somebody up and we change the way we do surgery. So it's all about the fixation of the fiduciary, how you put the frame on the patient. Okay, the percutaneous fixation, we'll use a bolt that goes into the, and we literally pound it in. That's a bolt that goes across the SI joint, or you can put it down the ilium. It depends how good the bone quality is, or a spinous process, or the reference frame. This is where you've had a patient who's had a previous procedure done, and you're going to go in and exchange out some of the screws, and we'll use a rod like this just with some dominoes. These are actually made now. I still prefer the homemade ones because I can adjust the position and angle where everything is, because you need to have the reference frame hardware out of the way so it's not interfering with the procedure you do. And this probably gives you the most rigid fixation. This is just looking back at some of the cost effectiveness and pedicle screw conformation techniques, looking at post-op versus intraoperative, and probably weighs out that it's actually going to be cheaper in the long run. Where do we use this technology? Basically top to bottom of the spine. Okay, I used to actually still use fluoro for some of my cervical cases. Anymore, I just bring it in and use it all the time. It's simpler. I don't have to work around a fluoro machine either. I mean, that's just one of the things of what I say. It's where you put all of the furniture in the room. This is an old study, actually, about C1-2 that we did many, many years ago, looking at stereotaxy as to when you could put C2 pedicle screws in. And I can't even remember the date on this, back in 2000. And it used to be said that 20% of patients had a vertebral artery that you couldn't put a pedicle screw in. It's really probably less than 5% when you have this kind of accuracy and technology. Nodding your head, you must have that same experience. It's a lot less. So the cervical spine, here's a patient that is having an anterior cervical operation. I don't do this very often, but occasionally I will. We don't necessarily fix the patient's head to the table, but you can with a Mayfield frame in a supine position just to hold the frame, because you can operate on the cervical spine after doing a CT scan, using navigation on the front side of the spine, just like you do in the posterior cervical. We will use a Mayfield frame that we put either front or back, and we can navigate both sides. It's actually pretty darn close. If you don't move the patient around too much and you don't lean on the patient, you can operate. You can operate on the front of the cervical spine, even though it's about 8-10 inches away. You know, because if you're off by a millimeter or two, it's okay. Okay, you're a good surgeon. You look in there and say, okay, I'm going to take this kind of accuracy. I'd rather know, you know, my millimeter away from the spinal cord or a nerve. You know, if you're a centimeter away, you're pretty safe. But, you know, you'd like to know if you're 2 millimeters away, be pretty happy. So the Mayfield's a key to doing that. And a lot of this is just creating your own system as to how these things will work. And here's just what it looks like for a posterior. There's a patient that's in position, had some kind of injury that has to have probably a fracture. in the prone position, and here's a reference frame in the upper corner. It shows you just how we mount things. It's so far out of the way, it doesn't interfere with your ability to do the operation. And again, this is what it looks like when we open the patient up. We'll leave the retractors in just because it won't shift anything. And these are just some of the studies that we've done. I'll keep going. So this is just some of the projection of what we do intraoperatively for a C2 pedicle screw. I mean, it just gives you that kind of comfort as to where you are. You've studied these patients beforehand. You can watch these things go in and you know where the vertebral artery is. It makes the procedure just so much safer for me. I've done this with fluoroscopy. I got to have 3D image guidance in my head if I have fluoroscopy. I probably know the anatomy better, or I have to know it better. But with this, I let the residents and the fellows do the operation nowadays. That's why I say it's really simple. Just do it perfect. You point, it's all about entry point and trajectory. So I know where the vertebral artery is, and I just tell them, get the entry point right. And then you stick the drill in, and all you do is you kind of wave it until it looks perfect, and then you drill. I mean, how difficult can that be? So we're kind of moving on from, the entry point and trajectory issues, but they still have to learn that. Here's some C1. I mean, we go through the base of the arch, which is on the back of the lateral mass of C1 to put in C1 screws. And it's a tight little trajectory. It's a long way from the spinal cord, but it's right next to the vertebral artery. So there's other things there. And these are just some of the C7 anatomy. We did a study and we looked at some of the cervical things, and this one hasn't been published yet, but the data is just so much clearer that our accuracy with regard to fluoro versus navigation is that lateral mass screws, we can put them in, but we never have a miss, or we never have something that irritates a nerve root that we would if we did it with fluoro or we do it with freehand. And a lot of them I used to just do freehand. I can still do them if we need to. Revisions are actually really rare. I'll keep going from this. So anyway, these were a few other studies. This goes back actually to 2010, and David Okonkwo, who comes to this meeting often, looked at some of their deformity patients and looked at some of the navigated versus fluoroscopy. Okay, got a clock on one of these. And looking at the accuracy of pedicle screws in pediatric patients is that clearly the accuracy is one thing. And this is what I said. I looked at this, and I think a lot of these things have been pretty clearly established as to how accurate the image guidance system technology is. I mean, you're looking at these things, with almost a real time. Is it truly real time? No. Is it something that you obtain the CT just, within the hour before? The answer is yes. And these are some of the studies looking at the accuracy in scoliosis. And it's really a place that, to me, it makes the most sense, is that revision, where you have patients, you don't have anatomy, but you can understand you have large patients that are big frame, obese patients, you can't fluoro them, you can't see any normal anatomy. Use the image guidance system. I mean, this is the kind of case that we do this on pretty much every day. We use this kind of technology. So. And these are just some of the pictures that you see intraoperatively. How to put iliac screws in. I mean, what a great way to do this. I mean, you can teach people actually reverse. You don't learn the anatomy, you don't learn how to do the procedure. It confirms what you do. But this is one place that you can confirm these kind of hardware placement. So what are some of the things that we're looking at now? Now that we're beyond, entry point and trajectory, we're kind of looking at how do we turn this into a high performance thing and make it work in the operating room. And these are some of the papers. We published, I think, about 7 or 8 papers in the past year. And this was about small pedicles, and it's just looking at small pedicles in the thoracic spine of deformity patients. This is using image guidance with thoracoscopic surgery, where we'd put a reference frame on the back of the patient. We'd do a CT scan, and we have image guidance, so I'm drilling inside the patient's chest on the vertebral body to do a calcified disc, as we do it from the front side, but it's navigated from the back where the reference frame is. This is looking at papers that we took tumors out of through the chest and through the back simultaneously. So we use the image guidance just in creative ways that we never have before. It'd be nice to know exactly where your drill is when you're going through somebody's chest and you're operating on their thoracic spine, and you want to know whether what the trajectories are, whether you're aiming at or away from the spinal cord, and whether you're 1 millimeter or 1 centimeter away. I mean, it just gives you that kind of comfort. Some of the other things that we use it for, I mentioned sacral tumors. Here's a sacral chordoma. I mean, this is a case that you could do without image guidance, but the oncology guys that do these kind of cases, they said, hey, come teach me how to use this image guidance system, and now they all use it, and they don't call me up anymore. But these are the kind of cases, they know where to do their osteotomies. I mean, this is one where you just say, okay, I'll point, shoot, and cut. It makes it a lot simpler as you know where you are. This is some of the accuracy of the small pedicles and just the numbers of what you can achieve with these tiny pedicles, where you've got scoliosis patients, especially on your concavity side, where you're going to have small pedicles. And if you're not using the pedicle, if you're going the in, out, in technique that we often do with small pedicles, this is one way that it just gives you more comfort in doing that. How about minimally invasive stuff? Here's some of the minimally invasive stuff that we do. Is that if you look at the incisions in this patient, okay, and I'll go through a case here, is that we use this in different ways. Sometimes we will do an A-lift on the front side of a patient, okay? You got a patient who's got a 4-5 or a 5-1, doesn't need to be decompressed, but they've got a degenerative spondylo with a lot of back pain, and if you look at it and you say, I can fix this, okay, without opening the patient up, they don't need to be decompressed. If you can do some kind of lateral interbody fusion or use an A-lift if it's 5-1 or something like that, then we do perk screws. And we do this with the image guidance. We will spin the image guidance, we put a perk pin in the pelvis, or if we need to, we'll open the midline and we'll put a clamp on the spinous process. And you can use guide wire technique. We've gone to using no guide wire. Okay, we don't even need a guide wire because you can actually just make a hole in the bone, you know where it is, use a jamsheedy needle, and you can go down and find the same hole. You can save the trajectories on the software, and you just go back and recreate the thing every time. Why do you need a wire? You don't need a wire. Okay, so I'll show you some of the save trajectory technology that we use. So this is actually a case, if you look at the upper right picture, it's a patient who had a fusion above. They wore out 4-5 and 5-1. They need to have a fusion, and it was purely a mechanical problem. We did this as a completely closed procedure from the back side. The front side obviously is an open procedure, and that's where the whole fusion is going to take place. We didn't even do a fusion on the back side. So here's one of your trajectories. Okay, here's your trajectory. It keeps going through, and you drill, you tap, you put your screws in, keep going. Okay, there's one level done. Here's L5. You're going to put another level in. Go back to that. When you finish that, you put a screw in, and see, you can save these pictures. Okay, so we know where we're going to put it. We don't have to see the patient. We don't have to see the open procedure done. It's all closed. So we have the trajectory saved of every one of these things. There's all three of them. Okay, and you know how big an incision we use to do this. We use a Wiltse lateral approach, and we'll use about 1.5 inch incision to do a 3 screws, 2 level fusion from the back side. And we'll use it without wires. So you go to the other side, and here you go. Repeat same procedure, okay? So there's your 4, your 5, here's your S1, and you can superimpose all these things. So you know what your rod length is going to be, you can measure the rod, and now you can put a rod in through a little small speculum. And you did a posterior instrumented fusion, and we can do these so quickly, it's amazing. Okay, so the speed of what you can do these things, is the other thing. Is that people say that once you get used to doing this kind of procedure, is that just recently, it actually was a case up at Davis, and they taught me, the guys up there taught me how to use the CT scanner, is that they'd put the reference frame. I did a thoracic kyphosis case for a Sherman's. And they said, okay, we're going to go do this thing. And they bring some things to the table. They say, well, do 2 CT scans. Put a reference frame in the middle and do a CT scan from T1 down to T6 or 7, and then you do from 6 or 7 down to L1. And so we power the screws in. Okay, all we do is we find a hole and we power the screws in. So we put in 24 screws in about 30 minutes. So does that speed you up? It probably does. So once you get to that point, and that's why I start talking about some of the things about this, some of the navigation things. And I'm going to show you a case here. It's interesting. Everybody says, what are the pitfalls? Well, right now it's reference frame technology, because if you have a reference frame that's off, you might end up with a post-op x-ray that looks like this. That's not very good, by the way. Right, something happened to our reference frame. I mean, this was very early on. I mean, we will go back and check and recheck. Fortunately, nothing. These things went into Camden's triangle at every single place. Missed everything. Big sigh, right? Yeah, you look at that and say it was just a perfect miss at every case. But this is, one of the early on. It's like you just have to have utmost respect for the guidance and use your reference frame with incredible accuracy. So what are some, and this is, I got to finish here. I got about 2 minutes left. So what are some of the pitfalls? Well, there's large machinery. So this kind of gets into some studies, and this is the current contemporary stuff, which we haven't published anything of this. But we're looking at this is basically it's a human performance. Okay, and we got some guy that's written a few papers that he works with the Department of Defense, and it's like, how do you make systems work? Okay, so he was working in the trauma surgical unit, and how do you make these systems work, and how do you make the flow go? Because you know what it's like when there's a trauma case come in, right? All right, we're trying to do this with elective cases, and you've got a lot of big machinery, and you've got a lot of things in the operating room. So we're looking at what are some of the human performance factors, and what do you do with all of these things that if you say, how do I make the efficiency work? Everybody has to be lined up because everybody knows that if you worked in an operating room, that if you could cut a minute here and a minute there and 2 minutes there, and you're waiting for somebody to bring in the CT scanner, you're waiting for somebody to bring this in, you're waiting for that, okay? This is all about organization and human performance, okay? And it also comes down to where do you put the furniture in the room, or where do you put these big pieces of equipment. And so anything, and here's some of the quotes, deviation from the natural progression of a procedure that potentially compromises their safety or efficiency, right? Okay, so somebody can't even get the drill to work or something like that. I got to get a new drill. How many minutes do you lose with that? So you can imagine if you're doing a big deformity case, it usually takes you 6 hours. That if you cut out some of those things, you probably can get it down to about 4.5. So that's what a lot of this stuff is about. And that's what we've looked at with some of the image guidance stuff. And then we've looked at also the human performance part is about the surgeon, okay? Does a surgeon have enough experience? It says my time's up, so I got to get going. Does a surgeon have the experience? And that's where you got to work on these things and you think about them. And so we're studying these things. We got a couple of grants. And this is what I say about it. We didn't invent this stuff. We're just trying to make it better, right? We're trying to make it work with efficiency. And so we're looking, and we got a pilot study we just completed. We did 48 cases with image guidance. And how many times do we do intraoperative CT scans? I mean, every one of these things, we're studying everything. It's amazing to me that all the things that we do that are just stupid, it's like, why don't we make this better? So we've actually, we're going to publish this pretty soon, and we got a bigger grant that we're going to do. And we've just looked at, so here's the surgeons. I mean, these are some of the different factors. Here's the scrub tech's contributions, the radiology tech, the image guidance tech, the circulator. Every one of these people affects the way your operating room works. And you add some great big machine like this, and then everybody melts down. Okay, so these are some of the things we looked at, just the difference between the experienced surgeon, and these two pie graphs here show you the rate at which the efficiency is affected because of all these things with your novice surgeon with image guidance and your experienced surgeon with image guidance. So if you want to do it, you just got to do more of it until then. So I'm about to finish, Rod. So this just gives you an idea about the applications of image guidance, the radiation safety, I think that's established. The accuracy, I think it's established in my mind. We're going on from here. We're looking at human performance and operating workflow and operating room systems, how to make them work. Because if we can get 30 minutes off of this time, just because it's like I told you, we did a thoracic pedicle screws, and it's like I was having a race with the other young attending who's up at Davis, and he put in 12 screws on one side and I put in 12 on the other side, and it was just boom, boom, boom. 35 minutes, we're done, and that's moving. And it's not in a hurry. I mean, it's just make things work. So where's it going? New image guidance applications are going to develop. Some of these things are going to come out. I'll come back next year and give this talk, probably a whole different talk. And then we're going to hear more about robotics. We're going to hear from, Izzy, we're going to hear from you, but there's robotics world is going to happen. So I'm usurping Rod here. So Rod and I are just talking about putting an image guidance meeting together here sometime in the coming year.
Yeah.
So if you want to come and learn about image guidance, we're going to have a whole program dedicated to image guidance. Right? Pretty cool stuff.
That's great, Pat. Thank you.
Hey, thanks for visiting the Seattle Science Foundation YouTube channel. To find videos just like this one, click here. To subscribe to our channel, click right here. Or check out our website here, or see what we do by clicking right here. Thanks again for watching.